Good afternoon, everyone, and welcome to this virtual event brought to you by the NAACP Boston branch and AdMeTech. My name is Anthony Crossan, second vice president of the NAACP Boston branch, and I have the pleasure of serving as your moderator this afternoon. We are excited and grateful that you have joined us to learn more about this very important topic that we have titled Prostate Cancer Awareness in the Era of the COVID-19 Pandemic. To discuss this topic further, we are joined by some amazing presenters, those on the front lines of this work who care deeply that the messages get out and greater health is realized in our communities. We want to make the most of this limited time that we have, so we're going to get right into it. The first Massachusetts State Representative Russell Holmes is more than a politician advocating for important causes in the Suffolk District. He is also a champion of the prostate cancer educational program for high-risk men with a priority focus on African American, Hispanic, and Latino individuals. He is here this morning or this afternoon to share his perspective on the COVID-19 pandemic in Boston and the importance of prostate cancer education and awareness. Please welcome him now as he comes, Representative Holmes.
Thank you, Anthony. Very much appreciate the introduction. I have to begin by saying, of course, thank you to the NAACP. We are, my wife and I, lifetime members, and it's such an honor to, of course, be lifetime members of the oldest branch of the NAACP in the country. Of course, want to give a shout out to also the president, Attorney Sullivan, for all the work she's done as the efforts, whether it be around voting, whether it be around education, and all of the many things that the NAACP does. But today we are, of course, here focused around Black and Latino men, and thankful for Dr. Stern and the entire AdMeTech team and all the presenters today. We know that through COVID, we in the Black community have just been disproportionately impacted by COVID. But the big thing more than that is we've also been disproportionately impacted by the fact that many of us are not going to our doctors. And I can tell you when I met Dr. Stern some 10, 11 years ago, and Dr. Stern came to the State House to say, hey, we need to get much more vigorous around what to do about prostate cancer. I got a chance to meet her dad, who unfortunately had prostate cancer and was able to recover. But just that relationship over the last 10 to 12 years has been flourishing as she began to, of course, to seek funding and to do things inside of this space to reach out to Black and brown people. And so I've just been so thankful over the years to work with Dr. Stern and the team, whether we are going into actual Concord Baptist, well, I shouldn't name churches, but into churches and to nonprofits. And again, of course, today with the NAACP and the folks who are here. The thing that stands out most in this conversation, when you think about us as Black men, we naturally, unfortunately, don't go to the doctors. And so when you're focusing and saying, hey, we're going to be particular about the fact that we're going to a population of people who just, our tendency is not to show up at the doctors, to not go get our regular physicals, to only show up after we're basically forced to by our mates. That is why things of this nature are so important. And then that has now been, of course, compounded with COVID-19. When you think about all the things that have happened within our communities, whether it be the unfortunate deaths that so many of us have had, the unfortunate incidents that we've had, but then also when you think about the Black community at large, the immigrant community. So often we think we're talking to just the historical Black folks who've moved up from the South through slavery and all the other stuff. But when you think about the resistance or the hesitancy, I should say, within our immigrant community, particularly the Haitian community, the Cape Verde community, folks need to hear these meetings. And so having Dr. Stern do exactly what she's been doing over the last 12 years, come to where we are, which has always been really my request. Come to where we are and don't try to get us to come to you because of the fact that we're already having difficulties just going to the hospitals and to our doctor's appointments. And so just as Anthony mentioned, I'm thankful for everyone who's on this call. There are incredible and great experts here. But I just wanted to just say, please encourage at this moment, encourage men, women, all of our children now that things have changed with COVID, to get your booster shots, to get your flu shots, to go and get more education of those that are not aware or still are resistant. Please do not go and try to force onto them that they must do this, but please try to encourage them to get more information because of the fact that we are, of course, dying at record numbers. And that also we want to just remind people, COVID is not over. We still have to get through the struggle of what's happening through flu season, through the winter, us coming back indoors. And so let us all continue to have our masks wherever we go. Of course, have our masks wherever we go. Let's still keep the basics still together, get our booster shots. And thank you, Dr. Stern and the whole team. And I'll be here for any questions or any other things that need to happen along the panel along the way. But thank you, Anthony, and thank you, Dr. Stern.
Thank you, Representative Holmes, for sharing your perspective on the topic. And we really appreciate you taking the time this morning. We want to continue on, and as we continue in our conversation, I would like to introduce Dr. Bisola Ojakutu. She is the Executive Director of the Boston Public Health Commission and has demonstrated an unwavering commitment to racial justice and health equity. Please welcome her as she comes to provide an overview of the current state and metrics of the COVID-19 pandemic here in Boston. Dr. Ojakutu.
Great. Thank you, everyone, and good afternoon. Thank you, Anthony, and thank you to the NAACP and to Attorney Sullivan, President of the Boston chapter, for all that you do. I have worked with the NAACP over many years throughout my career as an academic, from a research and a program perspective, community outreach. I really feel fortunate for that collaboration. So thank you for inviting me to speak with you today. Great. So while we're queuing it up, I just want to say that by way of introduction, I'm an infectious disease physician at Mass General and the Brigham, and I'm also an associate professor of medicine at Harvard Medical School. And as Anthony mentioned, I am the new executive director of the Boston Public Health Commission. I actually just started in September. And I think that there's been just an enormous amount of work to be done. Certainly, we are nowhere near the end of this pandemic. We have a lot of outreach that needs to occur and just a lot of awareness, because I think that health communication has been quite challenging throughout this pandemic. And I think that that's impacted a lot of what's happened in regards to the inequity that we've seen. Why don't we go to our next slide? Okay, so in the next 10 minutes or so, I'm going to review the most recent COVID-19 data. I will also highlight some ongoing racial and ethnic disparities and describe the Commission's work to address COVID-19 inequity. And if possible, or if there's time, I can certainly take questions, and I'll also provide you with my contact information. Next slide. Okay, so first, here are our latest data. Since the beginning of the pandemic, there have been more than 86,000 cases of COVID-19 in Boston, and unfortunately, there have been more than 1,400 deaths. Throughout the pandemic, people of color have been disproportionately impacted in terms of both disease incidence, so new cases, as well as mortality. Specifically, Black individuals comprise approximately 33% of deaths since the beginning of the pandemic, yet we're only about 25% of the citywide population. Next slide. So in terms of where we are right now, I think Representative Holmes's introduction and his words were very on point. Essentially, as I stated, we're nowhere near the end of the pandemic. We're currently experiencing what some people will call a surge in new infections. For a number of weeks, our positivity rate remained rather flat. It was even sort of going down for a while. And now we're up at 3.8%. What this means is essentially that many people are still at risk of new infection, even if they are vaccinated. And I will show you some data on that in a moment. But I don't think that any of this is surprising. Okay, I think what's happening now is to be expected when you're entering the winter. We know that we've been in this pandemic for quite a while now. Our guard is down. People are not masking indoors as they should. People are traveling more. We know that the more infectious variant, the Delta variant, is circulating. And there are also still unvaccinated individuals out there. The other piece to this is it's highly likely, based on the data that we know that's available, is that immunity is waiting. So we need to, as Representative Holmes mentioned, look at our boosters and obtain booster vaccination. And I'll tell you a little bit more about that in a moment. Next slide. So in terms of vaccination versus unvaccinated cases, I think it's important to emphasize here that most of the new cases of new COVID-19 infection are still occurring amongst individuals who are not fully vaccinated. However, the percentage of cases amongst those who are fully vaccinated has increased over the last week or so, from 34% to about 38%. And the point in me saying this and in showing these data is to say that, yes, you can be infected with COVID-19 and you can pass that onward, even if you're vaccinated. The purpose of the vaccines is really to prevent those severe complications. So it's meant to prevent hospitalization and death, but you can still be infected and pass it on to somebody who may be unvaccinated and may still be at risk for severe complications. So certainly this is an issue for us to pay attention to, and it's motivation for us to, continue to be vigilant and to get tested if you have symptoms, even if you're vaccinated. Next slide. So turning to vaccination data. So we're very lucky here in Boston. Boston has one of the highest vaccination rates among similarly sized cities in the country. And as of November 16th, about 76% of Boston residents have received at least one dose of a COVID-19 vaccine. And approximately 67% of Boston residents are fully vaccinated. So this is great news, okay? But the bad news is that we know that there are significant disparities by race, ethnicity, age, and neighborhood. And I'll show you some of those disparities. Next slide. In terms of disparities by race and ethnicity, the fully vaccinated rate is about 13% lower for Black residents of Boston, 11% lower for Latinx residents of Boston, and 42% lower for Indigenous people compared to white non-Hispanic individuals. And these data have actually been pretty persistent over time. So even though we put a lot of effort and energy into outreach, and I know that the NAACP has been involved in a lot of those efforts, we still know that these disparities do exist. Next slide. So turning to vaccination rate by age. So we're all aware vaccination among 5 to 11-year-olds began recently, so a couple of weeks ago. So here in this slide, I want to show you that amongst the 5 to 14-year-old age group, and that's just the way we grouped it for this data, or these data, you see that only about 32% have been vaccinated, or at least gotten one dose of vaccine. So we have a long way to go to get our younger population vaccinated. And that's, again, not surprising because vaccination just began in that 5 to 11 portion. But I would like to say that significant progress has been made amongst 5 to 24-year-olds. Now, there were, probably about a month ago, I was looking at these data with my team, and we had a very low vaccination rate in that age group, and now it's over 70%. So this is good news. There's been an enormous amount of outreach, both within Boston Public Schools, after school programs, other places where people really going to where people are at, meeting them where they're at, overcoming issues of low vaccine confidence. It's works. It has worked. So I think that's very important. I also want to mention, if you look at the older populations, we've really done a great job in terms of getting our older populations vaccinated. And this is really irrespective. There's still some disparities, but even amongst people of color, we do have a high proportion of individuals who are older, who are fully vaccinated beyond just these data, not just one dose, but fully vaccinated. So next slide. Disparities by neighborhood do remain. I think probably everyone on this call is well aware that there are several neighborhoods where we have lower vaccination rates. Notably, Mattapan has the lowest vaccination rate citywide. But I do want to say something positive here. In the last week or so, it has gone above 50%, which is something I couldn't say, a few weeks ago. So there has been an enormous amount of work with key stakeholders, with folks who have investment in that area of the city. And I would also say that what needs to be highlighted, and I'll refer back to Representative Holmes again, because I heard him mention non-U.S. born populations, Black populations, that we don't, in some ways, don't always include in the same way, because there may be different perspectives, different cultural norms within different populations, within diverse populations. And a lot of effort has been made to really engage people and meet them where they're at in terms of overcoming issues related to either not knowing where to access vaccines or not feeling comfortable with them. So this is actually a positive slide as opposed to something to be, concerned with right now. I definitely think we're going to see some increases over time. Next slide. Okay, so I want to turn to boosters very quickly. So at the end of last week, the FDA and the CDC authorized a third dose or a booster for everyone over age 18 after their second shot of the Moderna or Pfizer, or 6 months after the second shot of Moderna or Pfizer, and 2 months after the one shot of J&J. So I want to make a comment here that it's highly likely that this is just going to become a vaccine series going forward. So it would be 3 shots. But as we've looked at our data in terms of who is actually accessing this booster dose, it is concerning. So you see here that we only have about 36% of individuals 65 and older who have been boosted. And then if you look at lower age groups, a very low percentage of people have been boosted. And we know that there are people who have underlying medical conditions whose immunity may have waned at this point, or it may be waning, and therefore not their initial series is not giving them all the protection that they need. So this is certainly an area of concern for us. Next slide. And so looking at the booster data by race and ethnicity, because I think that that's obviously important. One of the things that we were very concerned about is this issue of health communication and who we're actually reaching with our messages. Of the more than 64,000 individuals who've been boosted thus far in Boston, 60%, more than 60% are white non-Hispanic individuals, and significantly lower proportions are people of color. So we have a lot of work to do in this regard. And I think this is something that we can serve as ambassadors in relationship to boosters. We can be passing on the information that you can go get your booster. Anybody can go get their booster, 18 or older, and they can get their booster and their flu vaccine at the same visit. It can happen at the same time. And there are, lots of different ways to access boosters, but I'll show you that in the next slide. Okay, before I get to how to access booster vaccine, I think in summary, we need to be mindful of the fact that new positive tests and positivity citywide has increased, and it's probably going to continue to increase, especially given the travel, given that people are not masking indoors and other factors. We know that vaccination inequity does exist, and it has sort of, continued throughout the course of time since vaccines have been available. And then we know that the low booster uptake is concerning, and certainly something that we're working very hard on. So I'll just say a few words about a number of these issues that relate to people of color, specifically Black African-American individuals, as well as Latinx individuals. So for 5 to 11-year-old vaccinations, one of the things that the Commission is doing is that we are standing up family-style clinics in 7 areas of the city. So in the areas of Mattapan, Dorchester, Hyde Park, and Roslindale, these are underway. They've been quite successful. What I mean by family-style is that anyone can bring, any member of their family. It's not just for 5 to 11-year-olds. We also provide first and second doses for anybody who hasn't had access yet, and booster dosing. So all of these are available to folks who come to those family style clinics. And though that information is available by calling the Mayor's Health Line, it's also available on boston.gov. I also want to mention that we are continuing to offer grants to our Vaccine Equity Coalition, which is community-based providers as well as clinical providers partnering together to really getting the word out about vaccination. It's been very successful, like the Black Boston COVID Coalition has been very successful in their operations and in getting people vaccinated. And then lastly, in terms of booster dosing, again, I think the key issue here is healthcare communication. I don't think the communication has gone particularly well in many ways throughout the pandemic, but specifically in regards to boosters, I'm not sure that people realize that it is something that you should be doing. It's not just sort of an optional thing. We're doing robocalls. We're working through our vaccine equity partners and other community partners to get the word out. And again, looking at these family style clinics, this is an opportunity for everybody to come and be vaccinated. So I'm going to stop there. And next slide, I'll just provide you with my email address. If you are at all interested or have questions about anything that I presented, please feel free to reach out. Thank you.
Thank you so much, Dr. Ojikutu. Thank you so much for the work, the information, all that has been done, all of your efforts to address this issue. I think a few things stood out. Representative Holmes mentioned that this is not over. This was echoed by Dr. Bisola, who mentioned that this is not over. We talked about being informed and staying on guard. Getting your the vaccinations or being informed about it. And we know that people have decisions that you make and do all sorts of things, but you have to know the facts. And wherever you are right now, we would encourage you to share this information widely with your networks, to let them know what the information is saying, what the metrics suggest, so that they can make the informed decisions for themselves. We're thankful for that. And now we'll continue on also. So I would like to introduce now Dr. Faina Stern, president of AdMeTech Foundation. AdMeTech established the Manogram project, creating a new standard of precision, individualized prostate cancer management, and reducing health disparities. efforts to adjust these things. Please join me in welcoming her now to discuss the importance of the prevention and early detection of COVID-19 and prostate cancer as the means of improving patient outcomes and reducing health disparities. She'll also outline current research and clinical advances in prostate cancer diagnostics. Dr. Stern?
Thank you so much, Anthony. I would like to thank you for your partnership, which made this event possible. And we certainly would not have been able to have this and other events of this kind across the state without support of Representative Holmes. Russell, thank you so much for your years and years of support. This program simply would not have taken off without your being our champion, as well as other members of the Boston delegation to the State House. And I will talk about this in a few minutes. Last but not the least, before my formal presentation, I would like to thank my staff, Thomas Satam, who's been absolutely critical to our advocacy and community outreach program. She was recently promoted to be my second in command at AdMeTech Foundation, and Emma Kayard, our outstanding intern from Clark University, present here today. Both of them are being very quiet because they're managing this event technically, but once again, without them, it would not have been possible. Also, I would like to acknowledge Ali Adam, another member of our staff who could not join us today, but who was also instrumental in making this event happen. Actually, concern about internet interferences, we pre-recorded my presentation. Emma, do you mind starting the video? I'd like to express my gratitude to Boston NAACP, President Tanisha Sullivan, Vice President Anthony Crasson, Health Chair Erica Florence, for the opportunity to address prostate cancer awareness in the times of the COVID pandemic. This event is a part of the AdMeTech Foundation's ongoing program in prostate cancer awareness and education in Massachusetts, with primary focus on African American, Hispanic, and Latino men. Our program was initiated since 2014 with strong support from the Boston delegation to the state legislature, particularly Representative Russell Holmes, who is participating in our event. Also, I'd like to thank Senators Bancory, Collins, Chandias, Representatives Honan, Miklevich, Maran, Santiago, Madara, China Tyler, and many other Boston legislators for their continuous support, as well as Dr. Alex Cole of the Massachusetts General Brigham Healthcare and Dr. Bisola Ajikutu of Boston Public Health Commission who are taking part in this event. Both COVID-19 and prostate cancer have emerged as leading health disparities in Black and Hispanic communities. In April last year, early in the pandemic, we have recognized that the areas of prostate health disparities directly overlap with the pandemic hotspots. Since May last year, we have expanded our program to include education about both prostate cancer and COVID-19, as reflected in this event. Prevention and early detection are critical for saving lives and eliminating disparities in both prostate cancer and COVID. The future of this pandemic depends on us. We can drive down infections drastically by wearing masks, particularly indoors or in crowded outdoor settings, in combination with reducing social contacts. If we develop flu-like symptoms, we can ensure early testing and self-isolation and help public health experts to trace our contacts. It is critical to detect COVID early when treatment is available to prevent severe disease. This treatment is effective when administered within about 3 days of the onset of symptoms. We can end this pandemic by complying with vaccinations. In Massachusetts, we are currently facing another rising wave of the pandemic. Masks are the best tool we have for preventing spread of infection. If most of us wear masks, we will flatten the pandemic, prevent countless infections, and save at least 1,000 lives. by March 1 next year. Vaccines are the best tool we have for ending this pandemic. On September 13, CDC reported that in fully vaccinated people, infections were reduced 5 times, with hospitalization and death reduced over 10 times. COVID vaccines have been proven safe and effective in millions of adults and adolescents, and more recently in clinical trials of thousands of children aged 5 to 11. Many experts pointed out that the vaccines could have prevented over 97% of hospitalization and death we are seeing today. We are much more likely to get into a car accident and sustain a serious injury than develop significant complications of the COVID vaccines. Vaccines are the best way to protect not only ourselves, but also our families and our communities. By accepting vaccinations, every individual helps us get one step closer to ending this pandemic. Since early last year, more than 5 million children were diagnosed with COVID. By the first week of September, new COVID cases in kids reached record levels. Our masks and vaccinations protect our children. Consequently, leaders of pediatric medicine issued a public appeal. Pediatricians are advocates for children and protectors of their health. Now we are asking for children to be made our national priority. Preserve their in-person education by mandating vaccines for all who are eligible and wearing masks in schools. Protect children with highly safe and effective vaccines. This expert joined the American Academy of Pediatrics in calling for rapid vaccine approval for younger children. Over the last months, it has been exciting to watch that vaccines were approved by FDA and CDC for kids age 5 to 11 and became widely available. Also in September, Boston Globe journalist Renee Graham wrote an opinion, "The unvaccinated and the orphans they leave behind." She pointed out that over 120,000 kids lost their parents or caregivers to COVID in this country, with Black kids impacted disproportionately. This article raised an important question. Can we allow our hesitancy and fear of COVID vaccines define our children's future? On July 27, U.S. Surgeon General Dr. Vivek Murthy shared publicly that he lost 10 members of his family to COVID. He pointed out masks help us reduce spread of infection, while vaccinations remain the key to ending this pandemic. While we are dealing with COVID, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable fear of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits and telehealth, ongoing in-person care, including appointments and testing, medical procedures, biopsies, and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. In prostate cancer, screening with blood test called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as African heritage, family history of prostate cancer, particularly brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors. Before screening, it is important to avoid exercise and sex, which may impact your testing results for about 1 week. It is also important to know that if you are in poor health or age 75 and older, the value of screening is limited. After screening, you need to ask your doctor if your prostate cancer test is normal or if you need referral to a prostate cancer expert. 2 months ago, AdMeTech Foundation held a virtual annual global summit on precision diagnosis and treatment of prostate cancer. Our summit brought together the key international opinion leaders representing every clinical expertise to achieve the following goals: educating medical community and general public, reaching consensus on the best emerging clinical practices and research priorities, expediting transfer of the cutting-edge innovations to patients, screening of prostate cancer with PSA blood tests reduced death by more than 50% and has been more successful in that regard than many other established cancer screening programs. Screening results in men aged 45 to 59 were shown to be important for assessing the risk of lethal prostate cancer long-term within 30 years. Depending on the PSA level, the majority of men usually have a low risk of prostate cancer and can be reassured. However, a minority of men have a high risk and need to be monitored closely. In men before diagnosis of prostate cancer, we have seen rapid advances in accurate non-invasive testing, which created a new standard of care. This includes blood and urine tests for molecular markers and imaging tools such as MRI. These tests improve identification of men who need to undergo biopsies and eliminate a lot of unnecessary procedures. Accurate imaging such as MRI has become a game changer in guiding biopsies. In this slide, MRI shows prostate cancer lesions and guides biopsy needles with great precision. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard biopsies. Our summit also highlighted the importance of assessing genetic predisposition to aggressive, potentially lethal prostate cancer. Testing for genetic mutations is particularly relevant for men with family history of aggressive prostate cancer and other malignancies, as well as for men diagnosed with aggressive local, regional, or metastatic prostate cancer. Genetic counseling is preferred prior to testing for men with family history and after positive test for genetic mutation. In men with prostate cancer, there are 2 pillars of the current diagnostics: MRI and genetics. While MRI shows cancer location and spread, what we call stage, genetic tissue analysis reveals underlying cancer biology and probability of progression. With this precision diagnostics, we can now accurately determine if each individual has a slow-growing, harmless disease and needs only careful observation, what we call active surveillance, or if a man has an aggressive prostate cancer requiring immediate life-saving treatment. More recently, molecular imaging has been shown to play an important role in detecting a return of prostate cancer after treatment and metastatic spread. For example, PSMA imaging has been approved by FDA within the last year and become available at the Dana-Farber Cancer Institute since August. On the left, identified by A, traditional bone scan shows limited metastasis. On the right, however, identified by B, molecular imaging shows much more extensive metastatic disease. This information is important for treatment planning. A recent large study in Veteran Administration Health System showed that with equal access to prostate cancer care, there were equal patient outcomes, including equal probability of death or mortality in Black and white men. And this health equity was independent of the level of education or income. Similar results have been reported in military medicine. Based on this and similar evidence, our summit concluded that access to care is the key factor in eliminating health disparities. It's particularly relevant to our state with its universal access to care. We are here today because with appropriate public education combined with access to high quality care, we will be able to achieve prostate cancer equity in Massachusetts. Towards this goal, we recently expanded our community education to include a program for improving access of high-risk men, particularly African American and Hispanic individuals, to high-quality clinical care. This program was created in partnership with experts from Massachusetts General and Brigham and Women's Hospitals, represented by Dr. Cole in this event. We have been working with men to match their individual needs with leading state experts in prostate cancer care and research, who have the most advanced screening, diagnostic, and therapeutic resources available today. Our clinical care equity program is open to any high-risk man interested in consulting a clinical expert like Dr. Cole participating in our event to address every aspect of their prostate health. This consultation may include an initial evaluation or a second opinion, virtual or in-person visit. You will benefit from this program if you are not sure prostate cancer screening is right for you and seeking more information to make a fully informed decision. If you had screening already but have questions about your results and the appropriate next steps. If you have been recommended an invasive biopsy and would like to learn more about the related options. If you have family history of prostate cancer and have questions about genetic counseling or testing. If you were diagnosed with prostate cancer and would like to learn more about treatment options. If you experience complications after biopsy or treatment. If after treatment you have questions about the next steps, including prevention and early diagnosis of cancer return or progression. Summer Mills, a member of the AdMeTech Foundation staff, serves as a statewide coordinator. If you have any questions, please contact Summer by phone, 617-523-3535, or by email, equityprojectcoordinator@admetechfoundation.org. In summary, prevention and early detection and related public awareness and education save lives and reduce health disparities on both COVID-19 and prostate cancer. Masks and vaccinations prevent COVID infections, hospitalizations, and death. Advances in screening and diagnosis created a precision, individualized approach to prostate cancer care. Thank you for your attention.
We thank you for that very informative presentation, Dr. Stern. And if you are watching, I hope that you are encouraged by the information as well. Surely you may be challenged by it also. We encourage you to watch this again after it ends and do something with the information. Well, we're really thankful for that. Thank you for sharing that information. I thought it was really encouraging to know the level of heightened detection that we're able to realize today. And I know that saves lives. So we're thankful for that. We want to welcome Dr. Alexander Cole to come now. He'll review academic perspectives on recent advances in prostate cancer treatment and related research. Dr. Cole?
Thank you very much for the introduction. I'm really thrilled to be speaking to this group today. I am a collaborator with Dr. Trin, who Faye Stern mentioned. We are currently working with the Boston Public Health Commission, the Massachusetts Department of Public Health, to try to improve access to care for Black men in Massachusetts with prostate cancer. And really, our research has shown over and over again in multiple settings that we can achieve excellent, outstanding outcomes if we do get access to high quality care in a timely fashion. I'm just trying to share my screen here. So my financial disclosures are listed here. I do have some research funding from the American Cancer Society and Pfizer. I'm also paid to treat and diagnose prostate cancer. I know that many members of the audience are not medical or not clinical. Very brief background on the prostate. It's a gland between the base of the bladder and the penis. Prostate enlargement is the most common source of urinary symptoms in men over 50. Prostate cancer is the most common cancer in men. 1 in 8 men will be diagnosed. 1 in 40 men will die from prostate cancer, and it's the second after lung cancer. Prostatitis is the most common cause of urinary tract infections in men. I'm going to be using a few clinical terms in my talk. PSA is a blood test that's used for screening, and it's elevated in men with enlarged prostates, as well as men with prostate cancer. I'm going to mention something called a Gleason score, which just refers to the appearance of the cancer under a microscope, and it tracks with how aggressive the prostate cancer is. And I'll also be talking about prostate cancer risk groups, low, very low, high risk. And this is just a tool that we use to categorize men with prostate cancer, and it's typically based on the PSA, the Gleason grade, as well as the cancer stage. I'm going to be talking a little bit about active surveillance and imaging in active surveillance. I'm going to be talking about focal therapy, which is a newer treatment that is targeted using imaging for certain men with intermediate risk prostate cancer. And then I'm going to switch gears towards the end of the talk and speak a little bit about treatment for high risk prostate cancer. It's very important to understand that prostate cancer exists on a risk spectrum, and the management of prostate cancer therefore also exists on a risk spectrum. And the treatments range from approaches which prioritize preserving function to the other end of the spectrum, where the approaches really prioritize cancer control. And I'm going to touch on topics at both ends of this spectrum in my talk today. Because we have increasingly used prostate PSA screening over the past several decades, there have been large increases in the number of men who are diagnosed with prostate cancer. This is an estimate that 1.3 million additional men were diagnosed from 1986 to 2005. 500,000 people more received surgery, about 500,000 people more received radiation, and many received both. Because many prostate cancers are not very aggressive, we've started using active surveillance. This is a tool to watch men with low-risk prostate cancer to identify when it's going to progress and hopefully avoid some of the toxicities of treatment. It has increased dramatically in recent years. And really what we're looking for in active surveillance is a way to follow men with lower risk prostate cancer to identify who would benefit from more aggressive treatment and who would not benefit from more aggressive treatment. And also men who might benefit from treatment if something were to happen at some point in the future. The problem is that active surveillance is not completely benign. Typically, we would perform a needle biopsy of any man with prostate cancer that we're monitoring, and these have risks of infection, pain, bleeding. These are not completely benign tests, although they're less aggressive than a lot of the traditional treatments for prostate cancer. These are two studies, one from the U.S. and one from Europe, and it's basically looking at who gets biopsies and who gets PSA blood tests on active surveillance. And the point of these, the lighter colored lines here, are the men getting biopsies, and it falls off very rapidly after diagnosis because these are not particularly pleasant tests for men to do. And there's been a lot of interest in my field about whether we can use imaging to avoid some of the toxicities of these biopsies. And this is a study from the UK where I did a portion of my training. And I don't want to get too far into the weeds of what this showed, but you can see these colored lines are survival curves. So ideally, we want to stay up near the very top of this. And if we see the lines starting to drop off, that tells us that men are failing active surveillance. In this case, they're progressing to a higher kind of prostate cancer, which might require treatment. And the green line here are non-visible tumors, tumors that do not show up on MRI, which is a kind of imaging test. The red line are visible tumors which have sort of a high risk characteristics in terms of the pathology. And the combination of the pathology and the imaging was extremely predictive of men falling off active surveillance. MRI seems to be telling us something about how these tumors are going to behave. And in the UK, again, where I did a portion of my training, we are really trusting MRI to do active surveillance. And this is how we use it on men with low and favorable intermediate risk prostate cancer. We enroll men who have MRI concordant lesions. We enroll them in active surveillance. We get a baseline MRI, and then we follow them with PSA blood tests, and we follow them with periodic imaging, and we only biopsy them if we have to. The chance of developing metastatic or incurable disease was extraordinarily low in this study, and most of those men were with visible intermediate risk tumors, but the absolute numbers, again, were extremely small. Overall survival in this cohort was also extremely good. This is not yet the standard of care in the United States, but there is clear evidence that MRI is tracking something with tumor biology, which may allow us to monitor men a little bit more closely, in particular men which are in an intermediate risk group, which historically would have been treated with a radical prostatectomy or radiation therapy. This can limit the morbidity of surveillance, and it can limit the men who need these more morbid radical treatments. The other interesting door that prostate cancer imaging has opened for us is the possibility of image-guided treatments. And I'm going to be speaking to you a little bit about focal therapy for prostate cancer. And this is a technique which aims to treat significant cancer in a way that preserves some prostate tissue. Historically, we would treat the entire prostate when you had prostate cancer. And the reason we're interested in doing this is to preserve function. And as many listeners are probably aware, the nerves that control erections are right next to the prostate, and the sphincter that holds your urine inside of your bladder is right next to the prostate. Both of these can be disturbed with prostate cancer treatments. It's new in prostate cancer. It's really not that new in other cancers. Breast cancer, lung cancer, kidney cancer, many cancers we approach by removing the cancer and leaving the healthy remainder of the organ in place. It's not yet widely used in prostate cancer, but we're starting to move in that direction. What do we mean by this? These are some schematics showing the way that we can treat prostate cancer in the prostate. You have a tumor here, you have healthy tissue, and you ablate or destroy the tissue surrounding the tumor, and you leave some healthy tissue behind. This is the nutcracker development, and the little cartoon here. I'm not saying that it doesn't do the job well. I'm just saying it might be a little more than it's necessary. And really what I'm talking about are radical treatments for intermediate risk prostate cancer. And these are data from the most mature clinical trial that we have comparing surgery and watts for waiting in prostate cancer. And we're categorizing men based on the Gleason score, 3 to 6, 3 plus 4, 4 plus 3, 8, 9. So again, these are those risk groups that I talked about. And when these numbers, which are for cancer survival and overall survival, when these numbers are larger than 1, it means that surgery provided a survival benefit. And interestingly, in this one group of intermediate risk cancer, the confidence intervals for these numbers actually cross 1, which means that the difference in outcomes between the two groups was not statistically significant. Again, raising the question, maybe a subset of these men with intermediate risk prostate cancer can receive a treatment other than radical prostatectomy or radical radiation therapy. We typically use this for Gleason 3+4 or 4+3, which is also called an intermediate risk prostate cancer. We get MRIs beforehand, and we assess men's suitability for these treatments based on where the tumor is in the prostate and whether we can reach it with these tools. We always involve men in a shared decision-making process around this. There are advantages in terms of urinary and sexual functions, but there are disadvantages. You're sacrificing some degree of cancer control. About 1 in 4 men need a second focal therapy. About 1 in 15, probably closer to 1 in 20, need some kind of radical treatment. They need to be committed to monitoring with a PSA blood test, MRIs, possibly more biopsies. And then there's some evidence that further radical treatments may be a little bit more technically challenging. There are a variety of delivery systems to ablate or destroy the prostate cancer tissue inside of the prostate. Some are heat-based, some are cold-based. There are a variety of others that are all listed here. I won't get into the details too much. I think the critical piece here is that the imaging allows us to understand something about the tumor biology, and then we can target our treatments based on what the imaging is showing. MRI visible tumors inside of the prostate differ from non-visible tumors in terms of the genetic changes in the tumor and the aggressiveness of the tumor. And that's why we believe that these treatments work for some men. There are sort of some technical details about how we deliver energy to different parts of the prostate that depend on where the tumor is, the size of the gland. Generally speaking, some of these techniques utilize small needles that are placed into the prostate. Some actually just transmit the energy through the patient's tissue and focus it on a area inside of the prostate. This is an example of a guy that I treated with HIFU, which is an ultrasound-based focal therapy. This shows the location of the tumor on the posterior, on the left side of the prostate. It's lighting up here very nicely. This is one of the delivery systems that we use for this. Again, we're heating the tissue with ultrasound, and you can see where we're focusing our treatment on the specific area here. This is an ultrasound image of the prostate that lines up with that MRI finding. In God we trust, of course, but all others, please bring data. So what are the data for focal therapy? There are a number of studies that have investigated the efficacy of these treatments. And the bottom line is it's not magic. There are trade-offs here. This is a study from the UK, early pilot study. This is an MRI after treatment of an area of prostate cancer. And these are not long-term data, but it's 12-month data, so 1-year data. And as you can see here, over 90% of men had no pads, they were continent, they had no leaks. A very large proportion of men had erections sufficient for penetration. And more than half of men had the trifecta. No clinically significant disease, no leaks, no pads, and erections sufficient for penetration. Here's a 5-year prospective study, also from the UK, where I trained, medium follow-up of 5 years. Failure, which means radical treatment, systemic therapy, metastases or death, 88% had failure-free survival at 5 years, which is relatively impressive. This is a very important slide, though. The top 2 lines, again, survival curves looking at men with low and intermediate risk disease. This third line includes men with high-risk prostate cancer, and you can see that curve falls off quite rapidly. So again, it's highlighting that we're really trying to select men who will benefit from this. But for those with higher risk disease, this is not an appropriate treatment. It does not tend to provide a long-term cancer control. Overall survival, this is a second multi-center study from the UK, 97% overall survival at 5 years. 6% of men, so that's where that 1 in 20 number comes from, needed to get radical treatment at some point within that 6-year period for this study. 1 in 4, 26% needed to get a second focal ablation procedure. Again, this is typically appropriate for this intermediate risk group, 3+4. MRI concordant lesion, which means the pathology and the MRI match up, typically peripheral posterior locations, motivated patients who are willing to follow these tumors with serial MRIs and serial PSA checks. Again, the concept here is really just balancing cancer control and functional outcomes. Counseling men, this is a new treatment. It's not magic, but for the right men with the right kind of cancer, this can be an appropriate treatment, which we're just starting to use more and more for this type of prostate cancer. I know I don't have a huge amount of time left, and I'm trying to cover a lot of ground here. I want to switch ground now to the other end of the spectrum. Active surveillance, focal therapy are appropriate for men with low and favorable intermediate risk prostate cancer. What about men on the other end of the risk spectrum, men with the highest risk cancer, where we really need to emphasize cancer control? And this is there's some controversy around what exactly constitutes high-risk prostate cancer. There are different definitions that are used, but generally speaking, these are men with high-grade tumors, possibly locally advanced tumors invading into some areas around the prostate. And the clinical concept behind this is that these are cancers which oftentimes require multimodality treatment. They're oftentimes tumors which require many bites at the apple, a combination of treatments to cure men with this kind of prostate cancer. And this category of prostate cancer is increasing relative to the overall, proportionally relative to the overall burden of prostate cancer in the US. This is a study we did a couple of years ago, and the high risk, which is this red group, as you can see, it's gradually taking up larger and larger portions of the total number of prostate cancer diagnoses. And we are increasingly willing to operate on these men because we are understanding more about the tumors. We have imaging that can tell us exactly where this is, and we can try to get all of this out and cure these men with a single operation. But one thing that came up, and I'm going back to the COVID-19 question that's been raised here, is how much is COVID-19 affecting prostate cancer outcomes? How much are delays in treatment affecting prostate cancer outcomes? This is a study that our group did here with Laurel Imucci over at the School of Public Health. We looked at breast, colon, non-small cell lung cancer, prostate cancer. There are a lot of numbers here, but we're comparing how long the delay was between diagnosis and active treatment and how that affected survival outcomes, how that affected overall survival outcomes. And the 5 and 10 year survivals are shown here depending on how long the delay was. The summary here really, and I'll cut to the chase, is that it mattered probably less for prostate cancer than some other tumors. But in that high risk group for prostate cancer, it mattered a lot. We responded to that, I should say. Various professional organizations came out with guidelines to try to risk stratify men who should get treatments during COVID-19. And this is what we did at the Dana-Farber where I work. For low-risk prostate cancer, for most men with favorable intermediate risk prostate cancer, we would typically defer treatment because we know that the biology was favorable for that. And what about those men with high and very high risk cancer? So we assessed the combination of surgery as well as something called neoadjuvant hormone therapy. And we mentioned here a specific clinical trial. And what is that and what does that mean? Neoadjuvant therapy is a medical therapy, typically hormone therapy, that's given before surgery to try to improve the outcomes after surgery. Historically, we found that this would reduce the chance of positive margins, it would reduce the prostate volume, it would make it easier to get the prostate out, but it never affected overall survival. So it was not recommended historically. But things have changed in the past 5 or 6 years. We have some new, very powerful therapeutic agents which target the androgen receptor inside of the prostate cancer cell and which target the creation of testosterone. just like taking water away from a houseplant, these medicines take testosterone away from prostate cancer and starve it so that the cancer shrinks and becomes much easier to kill. There have been a series of small trials coming out of our institutions where we gave men these very powerful drugs before surgery. Most of these were small sort of pilot studies, but we combined the results from all of these studies into a pooled analysis. And a small but significant number of men had a significant shrinkage in the size of the tumor, and a small number had no cancer at all. Furthermore, the survival after taking out the prostate in these men that got the hormone therapy beforehand was quite good. This is another study just emphasizing that increasing the extent of that hormone blockade before surgery seemed to be effective in reducing the amount of disease we found at the time of prostate removal. And based on these pilot studies, we've created a prospective 1,500 person trial, which is called Proteus, and that's underway at many centers throughout the world, as well as, and it's based here at Dana-Farber. And we are taking men with high-risk prostate cancer, and we are randomizing them. We're giving them hormone therapy alone or hormone therapy plus one of these very powerful new hormone treatments. We're taking out their prostates once they've had a period of treatment, and then we're following them with PSAs. And this study is accruing patients, and we don't have any results yet, but we're very excited to see where the data will lead us in this area. So just to summarize, hopefully I didn't go too far over. I know I've covered a huge amount of ground in a very short amount of time. Prostate cancer is on a risk spectrum. On the low and intermediate risk side, I feel, and I think the data bears this out, that imaging is a really exciting new direction for improving active surveillance and opening the door to some new treatments which have less toxicity. On the other side of the spectrum, high-risk prostate cancer, this is an area of prostate cancer treatment where oftentimes multiple treatments are required to cure men. And I would say that the principles in this area of cancer are really still multidisciplinary care, tailoring individual treatment. And there is a lot of interest, although it's still probably too early to tell whether neoadjuvant treatment before prostate removal has fully made a comeback. So thank you again for having me to speak, and I'll turn it back over.
Thank you, Dr. Cole. Thank you. Very informative. Every slide, I've learned so much, and thank you for doing the work that we might be able to realize some of those things. I'd like to welcome back Dr. Stern to add on to what was shared, to emphasize points that you may want to clarify and or take on a few questions that people may have. Thank you.
I apologize. I would like to start by asking if anyone on the panel has questions for me, for Dr. Cole, or for Dr. Ojikutu. Representative Holmes, do you have any questions?
Oh, I don't have a question. I just wanted to say thank you again for a great presentation. And that, as you know, several of my very good friends and constituents working with Devin and Ray before Devin were very, it was instrumental in this conversation when it comes to Black men about the thought initially years and years ago we would be very, very invasive and go and really attack anything that was found very aggressively. And then on multiple occasions, having it be much more a monitoring process has really worked out for all of those men. And so thankful that you're bringing this advice to all of the doctors, because of the fact that we as a community have to make sure we're very informed. So thanks again. And I think Devin's still in the call, but obviously as a person who represents the Blackest community in the Commonwealth and in my district, this is so important. I just don't want to get in front of any of the folks who might have a question for us as well. But thank you, and I'm here to answer any questions if anyone has them.
As usually, you are right on target, Representative Holmes. because with all the precision testing we have right now, we became much more selective in an educated way. Which men need biopsies, which men do not need biopsies, which men need treatment, and what kind of treatment they need. Just to work from the last point made by Dr. Cole about adding hormonal treatment, essentially, reducing the level of testosterone in men's body that feeds prostate cancer. We actually, at our summit 2 months ago, there was a very exciting presentation of clinical trial done between Washington University and actually University College London, that where Dr. Cole was trained, and they showed that out of 147 patients that were intended to have what we call androgen deprivation treatment, a reduction of testosterone, in 40% of these patients, molecular imaging changed management decision and actually showed negative results in terms of recurrence of prostate cancer, in terms of progression of prostate cancer or localized disease. And actually this in 40% of patients, physicians were able to, with great degree of comfort, not to even administer this treatment, systemic treatment, because imaging indicated no need for it. Overall, molecular imaging changed clinical decisions in 64% of men, at least. According to some studies, 75% of men. So
that's just a world of difference. And thank you. I can tell you
just like
3 or 4 cases for my folks who Devin or Ray sent, it was a world of difference. And so I'm really appreciative of the advances being made here.
And Dr. Cole, would you like, and this, we were in a privileged position to lead transformation and standard of prostate cancer care, research and education, and we still are, and we're very grateful for this opportunity because it would not have been possible without Massachusetts legislators like you, Representative Holmes. Alex, do you want to comment on percentage of patients these days that are getting no treatment at all, which was careful observation, active surveillance, or focal treatment, as opposed to radical treatment? If you look at the last 10, 15 years, do you see changes of pattern of care, and in what direction?
So that's a great question. I think that there are so many different trends that are at play here. Absolutely, there has been an increase in the portion of men who choose active surveillance for low-risk prostate cancer. There is another trend, which is that PSA screening has decreased as a result of a variety of factors, which means that proportionally there's more higher risk prostate cancer in terms of the total pie. So there are kind of at least two effects, and there are probably more. But generally speaking, the numbers for active surveillance for men that are appropriate for it, probably, it depends on where you look, but the studies range from around 30% in some of the things that we've looked at in hospital databases to well over 50%. So there's probably still a good amount of overtreatment of low-risk prostate cancer. In terms of the question on focal or image-guided therapies, that is really, really hard, and I'm actually putting in grants to try to figure that out right now. This was there was a rule change at CMS in January 1st, 2020, where they approved a CPT code to pay for this, which means that Medicare is now recognizing this therapy. Previously, this had been a kind of a cash pay niche procedure, and as a result of that, it was really hard to study who was actually getting that. But now we actually have Medicare claims. Medicare is paying for these treatments, so we have the ability to see who is getting this. And I think one of just to get into the question of racial and ethnic disparities, one of the terms that I throw around that I think is fairly accurate is that I think there is something called an access paradox with a lot of this stuff. Take germline genetic testing. It's indicated for men with regional or high-risk disease with certain pathologic factors. Black men are much more likely to fit into these categories. But we've studied this in surveys, and Black men are less likely to receive these treatments. MRIs, okay? Deb Sunday's study, Black men are more likely to have anteriorly located tumors, which require MRI-guided biopsies. But again, Black men are less likely to get MRIs and therefore less likely to get MRI biopsies. So it's a group that paradoxically would potentially be more likely to benefit from some of these advanced molecular and image-based treatments, but are actually, as it turns out, less likely to receive them. And I think that's a really important area to push, and especially for men who have distrust of the health system or concerns about effects on potency, sexual function, urinary side effects. Focal therapy is maybe an answer for some of those men, but we have to make sure that it is, as we start rolling this out, and we're starting to do this in December at Brigham and Women's Hospital. We're starting to do this in December. The first case is off trial. We want to make sure that we're doing this in a way that's equitable and that is available to all men who might benefit from this.
Great points, Alex. And I would like to emphasize that our program, Prostate Cancer Clinical Care Equity Program, is addressing exactly these issues to make sure that all men, particularly African American and Hispanic men, will have access to the right treatment, will have access to the right diagnostics, and will have appropriate care. So if anybody is interested, please contact me or Summer Mills at 617-523-3535 in order for us to offer you the best medicine has to offer today. Now, Alex, another aspect, but if I were to highlight one point made by Dr. Cole, I would say, and I would like to bring this to everyone's attention, is that before, if we looked at the 10 years ago, there was almost no active surveillance to speak of. And over the last 5-10 years, there was, as Dr. Cole pointed out, there were 30 to 40% of patients who undergo active surveillance, which means no therapeutic interventions, just monitoring, which means that they do not have treatment complications because of improvement in diagnostic tools, etc. So this is something, and of course we have also minimally invasive treatment on the way. That's why it's very important for Black men to ask their physician after screening, is my screening normal? Or do I need to be referred to prostate cancer expert who can sort out the next appropriate steps? Now, Alex, I also want to use this opportunity to ask you about latest approaches to biopsy. And that is, historically, men would have screening, would have abnormal screening, and they would automatically undergo biopsy. Would you be comfortable, given the current evolution of multiple urine tests, blood tests, imaging tests, would you be comfortable sending men for biopsy without this liquid diagnostics or imaging?
You know, this question comes up a lot, and I think I have a privileged position in this, having worked in Europe and in the U.S. For me, imaging is really key here, and most American doctors that treat prostate cancer, I would say, probably would still recommend a biopsy for anyone with an abnormal or elevated PSA. The question that a lot of people wonder is whether we can omit a prostate needle biopsy in a man, say, with a slightly elevated PSA and an MRI that shows no evidence of prostate cancer. I'll tell you that in Europe, the European Urology Guidelines recommend that approach. NICE, which are the UK guidelines, recommend that approach. It is not yet the standard of care in the United States. However, I think that it's a place for shared decision making. And it's true that imaging and molecular tests aren't perfect, that you do miss some prostate cancers. However, you also miss some prostate cancers just doing a routine sampling biopsy, which we did for 20 years. And I think there's no question that MRI is better than that. So, it's a conversation I have with men that I treat. I think at the end of the day, you just have to be honest about what the data are, what the tests can tell us. But we're seeing improvements with prostate imaging, molecular testing, and that's certainly the goal. Is that this can be the kind of cancer where we don't have to put a needle in a man to diagnose or to rule out prostate cancer.
Great. Thank you so much. As Alex pointed out, biopsy has its own implication in terms of costs, in terms of complications. And if we can avoid biopsy, it is a great thing. So that's why it is critical that you consult an expert and sometimes get a second opinion before you get biopsy or before you get treatment, just to make sure that you had the best possible diagnostic evaluation to make sure that biopsy or treatment is needed. Dr. Ojikutu, about 1 month ago, you made an incredibly important point about compliance in adults with booster shots. Okay, of course, children are the most precious thing, the most precious members of our family. 1 month ago, we had FDA approval, FDA CDC approval for kids, not only for adolescents that we've had for a while, but also for kids age 5 to 11. In medicine, we very frequently consider if we would be comfortable to make the same recommendation to our family members, to our beloved community members, that we would to any patient we see. Would you be comfortable recommending COVID vaccines approved by CDC and FDA for children aged to 11 or to adolescents in your community or in your family?
Well, thank you for that question. Absolutely. I have a 5-year-old and she received her first dose about 2 weeks ago. So I would absolutely recommend it. So if you look at the clinical trial data that Pfizer released and then, of course, sent to the FDA and the CDC for review, overwhelmingly, the vaccines at the dose that they're given, which is 1/3 the dose in adults, they're safe. The Pfizer vaccine is safe. There really weren't a lot of adverse side effects, and most adverse side effects, we usually see those immediately following vaccination, so within weeks as opposed to being longer term. So that's a piece of it. The kinds of side effects that people are seeing are similar to those in adults. So soreness in the arm, some fatigue, maybe some myalgia or muscle aches, but nothing that would stop one from wanting to get their child vaccinated. I think that what we need to realize that's really very important is that though severe complications from COVID-19 are rare in that age group, and I want to emphasize that. So severe hospitalizations and death are rare. They do occur, and they do occur more commonly in children with underlying medical conditions. And there are more children who have, say, diabetes or obesity who are children of color. So if you look at those children who've actually died from COVID-19, those are children of color. I mean, by and large, that's quite striking, and it's something that we need to be very aware of. The other piece of this is when we're talking about the social, emotional, and educational health of our children, we need to keep in mind that we want to keep them in schools. Okay, and we know that that transmission is occurring in schools, and one thing that we can do to decrease that, as well as to decrease the more severe side effects, is to get kids vaccinated. So if we want to keep kids, in schools and at the same time keep them healthy, I think that it's really important for us to, consider vaccination. I would also just add to that though I'm a proponent of vaccination, I do understand parental hesitancy. I think that no one can, put that aside. I think that, parents, are certainly concerned about anything new that they're giving their child. But I don't advocate something that I have not done myself. So as I said, I do have a 5-year-old who has been vaccinated.
Thank you so much. Dr. Jakuto, what would be your take-home message about masks and vaccinations to people who participate in this event?
So I think there are probably a couple. One, this has been said already, but one, we're not out of this pandemic yet. Cases, particularly here, as well as other places across the country, are rising. Unfortunately, we are going to see more cases and more hospitalizations as we enter this sort of winter period. And that's something to certainly keep in mind. We should be masking indoors. That's, sort of something that, is really important, particularly around, say, we enter the holiday season and we have family members who may be unvaccinated, known to be unvaccinated. You should be masking around your family members who are unvaccinated, as well as friends. I know that may seem like an uncomfortable thought, but that's the reality. A very large BMJ meta-analysis recently demonstrated that masking in and of itself decreases the risk of COVID-19 transmission by 50%. Okay, so masking does work, okay? But in addition, we should be getting vaccinated. Now, obviously, Thanksgiving is just right around the corner, so you're not going to get your full protection by Thanksgiving, but certainly as you think to December, we should be getting vaccinated. And if you need more information regarding vaccination, certainly we have a lot of information on the Commission, bphc.org website.
Thank you so much. Alex, what would be your take-home message overall to people who view this video, for people who participate in this event?
So I think that the take-home is that prostate cancer is complicated, and it's on a spectrum, and there are advances at both ends of the spectrum that can really help men do a lot better with this disease. We just have to make sure that they're getting to the guys that can, most benefit from these advances.
Thank you so much. So I think that our discussion is over, and I am turning over to you, Anthony.
Absolutely. Well, we would like to thank all of our presenters for sharing this very important information. We've talked about prostate cancer detection. We've talked about screenings. We've talked about vaccinations for COVID-19. A lot of information has gone forward. And this information will be available online as well via Facebook at the AdMeTech website, as well as the NAACP Boston branch website. So it's accessible. Please take the information, use the information, share the information. But special thanks to all of our presenters for sharing this information. Everyone offered a perspective that allows us to move forward with greater confidence, really. We stand with you as you continue to challenge inequity and fight for freedom and justice. We'd like to thank everyone who joined us this afternoon. And our hope is that whether you've heard this information today or will hear it in the future, that you'll be educated, equipped, and empowered to better address prostate cancer and the COVID-19 pandemic. I'd be remiss if I did not acknowledge the entire NAACP Boston branch and our executive board who helped really bring this to life. So President Tanisha Sullivan, Vice President Cheryl Crawford, Third Vice President Arthur Kaner, Secretary Farouk Sahabdeen, and Chair of our Health Committee, Erica Florence. Finally, we recognize all of our prostate cancer survivors and remember those who have passed fighting well. We honor you and hope that others will continue to honor them with their own detection, screening, preventative efforts, and vigilance. Thank you so much for everyone who joined today, and have a good rest of the day. Take care.